la Dr Christine McCusker. Elle a obtenu son baccalauréat en immunologie microbiologie à l'Université de Toronto. Elle a complété une maîtrise en virologie moléculaire à l'Université McMaster et a ensuite sa formation en médecine à l'Université McMaster. Elle a fait sa formation en pédiatrie ainsi qu'en allergie et immunologie à l'Université McGill. Elle est pédiatre et allergologue à l'hôpital de Montréal pour enfants, où elle est la directrice de la division allergie, immunologie et dermatologie. Elle enseigne l'immunologie au premier cycle et au cycle supérieur et organise le cours d'immunologie pour les étudiants en première année de médecine à l'Université McGill. Elle est aussi une chercheure clinicienne et professeure agréée de McGill, avec un laboratoire fondamental situé au laboratoire Mickens-Christie. Son programme de recherche est axé sur le rôle des environnements en début de vie lors de la formation du système immunitaire et la prévention de l'asthme et des allergies chez l'enfant et l'étude d'un nouveau traitement pour les allergies et l'asthme. Elle est le chercheur principal de C-Prime, le registre canadien pour les patients atteints de PID et AOH. Accueillons la Dr Christine McCusker.
Bonjour. Au premier, je voudrais vous remercier. Je vais chercher des choses. Pour l'invitation de discuter avec vous au sujet de C-Prime, le registre pan-canadien pour les gens qui ont des immunodéficiences premières. Mais je voudrais continuer maintenant en anglais, mais toutes mes fiches sont bilingues. Oh, I don't know where they are. So just to start off, I need to point out that a lot of the work that we do in C-Primes has been funded through unrestricted research grants from various companies, including CSL Behring, Grifols, and Baxter. So what we're going to do today is to discuss the challenges that come with a diagnosis of primary immunodeficiency and what the role of patient and physician networks are in improving access to healthcare, improving healthcare services, and improving quality of life for everyone who lives with primary immunodeficiency. And we're going to talk about C-Primes, which is an initiative that we started several years ago as a pan-Canadian registry for patients with primary immunodeficiency and hereditary angioedema in Canada. So to start with, the first question that we have to ask ourselves is why do we require a registry for primary immunodeficiency? And essentially, if you want to look at healthcare as being a big haystack, looking for primary immunodeficiency is sometimes a little bit like finding the needle in the haystack. And when there are healthcare dollars that are being used for diseases that seem to be much more frequent, it's hard to advocate for adequate access to care, adequate training of physicians and allied health professionals for managing and treating patients with immunodeficiency, as well as advocating for resources that extend beyond the healthcare system. And in order to do that, we need information and we need data, and we need to provide the institutions that decide how to allocate these resources. We need to provide them with information about what is needed, what is required, how many people are out there, and what are the benefits of providing these resources to patients. And in order to do that, we need to collect that information. On the other side, as many of you are aware, when you walk into a healthcare institution and you have something, finding the access point to looking for the good care is sometimes very difficult. And so if we have a registry, if we have information, resources that we can provide for the patient that are Canadian specific, that are not based on things that are happening in the United States or things that are happening in Europe, then we can advocate properly so that patients can find timely diagnoses, timely care, and proper resources that they require. So if you look at primary immunodeficiency, at the present time there are approximately 229 different mutations that have been diagnosed, that have been found in the immune system that lead to primary immunodeficiency. That doesn't actually include other immunodeficiencies that are found associated with other diseases, but this is known 229 mutations. Each one of those mutations can lead to a disease that has a subtle variation. And the example that we give is always the disease of common variable immunodeficiency that I know many of you are quite familiar with. And as you know, the genetic mutations associated with common variable immunodeficiency actually only comprise about 10% of patients with CVID. What does that mean? That means that 90% of patients don't yet have a genetic diagnosis, so aren't included in this 229, number one. And number two, what that means is that we have several different diseases that are all under the same umbrella of common variable immunodeficiency. Does that mean that every patient is going to behave in the same way? Obviously, if there are different causes, there are going to be different problems associated. And we need to figure out how best to treat the patient in front of us, not the group. And the only way that we can do that is to figure out not only what are these mutations, what are the different mutations that are found with different patients, but also if we have 5 patients all with the same mutation, we can then say, okay, you can then be expected to maybe go through this path. And so we can provide more personalized, more precise care to each patient. And again, this is just an example of the different types of immunodeficiency that come under the big umbrella of primary immunodeficiency. And it can extend from anything from the newborn baby whose immune system isn't functioning from the beginning and requires an immediate bone marrow transplant, to the 75-year-old who discovers that they may have a defect in the way in which their neutrophils burst. And they haven't had any problems per se except for grumbling infections. So this disease group, or in fact I don't really consider it a disease group, manifestations of health that is suboptimal really, can start at birth or can present at any time during the age range. So it crosses all phases of life. There are many causes, many prognoses, and management has to be individualized. And the only way we can do that is to be able to have information to choose appropriate diagnoses. In addition, however, it makes it very difficult to advocate for a given disease if we're only going to pick one of them. If we say, okay, we're going to focus on common variable immunodeficiency, and that's the group we're going to look at, we are actually missing a whole population of patients. The WHO estimates that primary immunodeficiency occurs in 1 in 2,000 individuals. If you look around this room, there is not 1 in 2,000 individuals just from the province of Quebec represented. Why is that? It is because we are not recognizing, we are not identifying, we are not diagnosing, and therefore we are not treating these diseases properly. And we need to do better. So I will give you an example. This is an example that occurred at the Montreal Children's Hospital. It was a 13-year-old boy who presented to the hospital in February. He presented with autoimmune hemolytic anemia and nothing else. I can tell you in all honesty, fair disclosure, I was the physician doing a moonlighting shift in the ER. I was the one who saw him. He had a hemoglobin of 50, and those of you who know that hemoglobins realize that that's extremely low, and he had autoimmune hemolytic anemia. I treated his autoimmune hemolytic anemia and failed to notice that he had profound lymphopenia. When he finally came back to our service a couple of months later, we diagnosed him with his combined immunodeficiency. But what it tells you is that everybody can miss primary immunodeficiency, and we need to continue to hammer home the education component of physicians, even those that are supposedly experts. Okay, it's an embarrassing moment, but I think it's important. And also to continue to push forward on our recognition. So as individuals, now that's a rare case. It's extremely rare that a child at the age of 13 with no previous history will present with a combined immunodeficiency. But it happens. And we need to keep our sensors up high. We need to keep those diagnoses in the forefront of everybody's mind. So one of the questions that we asked at the Children's several years ago was there a way to pool our expertise? The number of qualified specialists in immunology in Canada is very few, which means that we need to find a way to maximize the way we disseminate information, the way we pool our expertise, so that we can provide optimal care and keep everybody informed. So what we decided to do was to set up a cross-Canada registry of patients with primary immunodeficiency. And we called it C-Primes, Canadian Primary Immunodeficiency Evaluation Study. And basically, what it's designed to do is three things. Number one, it's to try and capture everybody's information. It captures it in a way that doesn't identify the individual. So it's not like anybody can walk up to a patient in the registry on the street and say, aha, I know who you are. But what it does is it captures their medical information so that we can pool what is going on in our various areas. Because it is captured locally and then provincially and then nationally, we can capture what's happening in the microcosm that is Montreal or Quebec. We can capture the microcosm that is the province of Quebec and the microcosm which is functional in Canada, because truthfully we're a very small country. Lots of space, few people. So altogether, what that does is it provides us with power numbers. Because if I know that there are 25 patients with common variable immunodeficiency in my little microcosm of Montreal, and we expand it to the number that are in Quebec, we can then advocate for resources to support that population. Whereas if I only know about 1 or 5, it's a much lower number to begin to advocate for. And then the other part that this is important, the second part of this, is to disseminate information. Is to disseminate information to other physicians. Oh, by the way, did you know that low lymphocytes and autoimmune hemolytic anemia can mean immunodeficiency? Nobody knew that before that case. So that was an important piece of information. It allows for sharing, so that when a physician in Halifax phones us up in Montreal and says, we have this particular group of problems in this patient, can you help us with the diagnosis? We can do that. We can offer that resource to that group. In addition, we can then disseminate the results of the information that we got from that group to other people. Did you know that patients who have IRAK4 deficiency are at risk for this infection because their immune systems don't function that way? Not known before we did that study. And that information then went to BC, where there was a patient population there, and helped treat them. So we can provide information, and it's information that can be disseminated in real time. It doesn't have to wait for a congress. In addition, that information can be disseminated back to the patients, back to the population who need to know. Because we can do that through a website that will allow us to feed back all that information. And then finally, we've used this tool in order to permit and facilitate collaborations that are going on internationally. Diagnosis of the genetic causes of primary immunodeficiency cannot be done efficiently in a country the size of Canada. We can get to a certain place, but we can't really push things forward as easily as we can if we can provide information on a global scale. So we have used this tool, our C Primes registry, to enter into international collaborations and come up with novel diagnoses for patients in our group who are one of 26 in the world. But we know what everybody else, those other 26 patients look like. We now know what the genetic defect is associated, the mutation that's associated with that disease, and we know what's happening and what we can anticipate for the children that we have with these diseases. So if you look, so far, we have centers in Newfoundland, in Halifax, in Nova Scotia. We have 3 centers in Quebec. We have 2 centers in Ontario. We have a center in Calgary, 1.5 is coming up, that's why it's still in yellow. And a center in BC, all of which have begun to participate in C Primes. So we are moving across Canada. So it's a bit of a slow process, but that's the way it is. So what do we have so far? We have full recruitment of over 200 patients, and that's really in the Montreal-Ottawa corridor. We have primary physicians who have patients with primary immunodeficiency are able to register their patients, so it doesn't have to be an immunology specialist. We have patients who come from Val-d'Or, we have patients who come from Rouen, we have patients who come from all over Quebec who are able to be registered through their primary care physician because they don't necessarily access an immunologist on a regular basis. That also allows the opening up of a dialogue in a corridor between that primary group who are in a remote area and the specialist physician who may not be in a remote area. We have presented our data nationally and internationally, and I've given you a couple of examples of where it has implicated and impacted patient care and patient diagnoses in real time. We have Canadian collaborations now across Canada. We are working very hard to keep our exchange of information as open and as moving backwards and forwards in real time as possible. And we are using this for our advocacy so that we can advocate for patients with primary immunodeficiency. Another classic example that does not affect patients of Quebec, but in BC, the BC health government decided that they would try and limit the amount of gamma globulin that patients with primary immunodeficiency could receive. They decided that they would take the minimum amount and they would say that's the dose you're allowed to give. Now, as many of you are aware who are not on the lowest dose, that patients have needs in terms of gamma globulin replacement therapy is very individual, and some patients can be maintained with good health on a low dose of gamma globulin replacement, and some patients need actually significantly higher doses. And there is this concept of updosing to health. So you updose until you're in good health and good control. Well, if the BC government had been permitted to have that rule in place, those patients would have lost out. We were able to sort of rally some numbers together to show that we needed ranges of gamma globulin dosing so that patients could maintain their sense of health, which is really the goal here. It's not curing immunodeficiency. Unfortunately, we're not there yet, although truthfully there are studies that are coming that are going to be very interesting in the future, but we're not there yet. But we are trying to maintain health, helping people live with their immunodeficiency. So, how do you become a member of C Primes? Well, if you're a physician, number one, and this is the hardest part, is that we have to get ethics approved at regional and local institutional ethics boards. That can be a bit of a cumbersome problem and tends to be the reason why a lot of physicians just don't get to it. We have tried to facilitate that, so anybody interested can advocate to their physician that they contact us. So we have a research coordinator by the name of Duncan Layton, who some of you have met previously, and Duncan will help facilitate the process that is needed to provide ethics. Once ethics has been obtained, then any patient who qualifies under the guidelines of primary immunodeficiency can be registered. What does registration mean? It means that you sign consent saying that you will allow your medical information to be used. Once a year, you might be asked to fill out a quality of life survey so that we understand how well you're doing with primary immunodeficiency. And over time, some of the data might be captured. Once the consent is signed, you are assigned a number, which means that there is no names, no identifying information attached to that data. The data is used only as data. Now, if patients are required to do other things, so if we decide that we need a study on common variable immunodeficiency and we want to know about B-cell function and common variable immunodeficiency, you may be contacted. Do you want to participate in this study? So that's the other thing. And you can always refuse. You can refuse contact. You can refuse anything. And you can withdraw at any time and your data will be deleted. So we're still working on it. But certainly data from the European Society, data from the American Society tells us the power of registries in terms of providing information and better resources for patients with immunodeficiency. We're learning a lot. We've already made strides and we can see the difference with some of our patients. And with this tool, we're hoping in the long run to be able to provide a good picture of what's happening across Canada, provide good advocacy, dissemination of information, and better healthcare and better resources. And that's all I have to say.